All right, I'm going to go ahead and get started here. Just a reminder for our partners across the world to please fill out our Red Cap survey. It's a needs assessment so that we understand if what we're offering here now to you and if it's really what is required or needed, or if there's anything else that we're missing, or what would be good for this collaborative. It would be really helpful for us to know. I'll throw this slide up again at the end for those who are just now joining. Okay, so I have the great pleasure of talking to you about my favorite topic in the world, which is the right ventricle, or as some people call it, it's the forgotten ventricle. And you think about it because when you ask somebody, how's the heart doing? They always tell you about the left side. They always report, oh, the heart's good. What does that mean? And everyone forgets about the right ventricle. But I am here to kind of share with you that I believe that the right ventricle is the people's ventricle. Without the right ventricle, the mighty, muscular left ventricle cannot eject blood to the rest of the body and steal all the glory. The LV needs the RV, and we should not forget about it. So why should we not forget about it? Well, let's talk a little bit about what the RV is. The anatomy of the RV is really important for the way that it functions. It is crescent shaped. You can see that here. It has an inlet, which is what comes into the RV. The apex is typically quite trabeculated. You can see that here, how all these trabeculations exist in the apex of the RV. And then it has an outlet, and that outlet goes up into the pulmonary vasculature. It's relatively thin walled, and you get a real sense of that when you compare it to the LV here. Look at how thick it is compared to this thin walled RV. And it has a very large free wall. Look at how big this free wall is of the RV. And the way that it contracts, although is simple, appears quite complex because it has predominantly longitudinal fibers, but those longitudinal fibers basically travel across dimensions when you're looking at a 2D image. So when you're looking at the RV at the base of the RV, notice how it looks like it's bouncing up and down like a piston. This is an apical four-chamber view. This is the left ventricle. Here's the right ventricle. And look at the base of the right ventricle. It looks like it's bouncing up and down like a piston, up and down, up and down. But then as you move kind of to the mid portions of the RV to the apex, notice how the walls appear to be coming in and out. So it looks very complex in the way that it's contracting because those fibers basically travel around the left ventricle, and it's hard to capture that in a 2D image. Also, there is a component of physiology because of the left ventricle that really affects the RV. So if I'm just going to try to go back here. For some reason, hold on one second. Steve, can I make you co-host real quick?
Yeah,
Are you
sure.
okay? I'm just gonna do that because I can't admit people when I'm sharing my screen. So maybe that could you help me admit
Yeah,
folks?
yeah, sure.
Thank you so much. Okay, that should work now. Let's try this again. Okay, great. So the one of the reasons why the RV physiology is so complex is because it shares a septum with the left ventricle. You can see the LV here in yellow, and then the RV wrapped around it in blue. And there's a septum that is shared between the two. So something that affects the septum of the LV will also affect the RV, its function, its filling. The RV wraps around the LV, as you can see here, almost like a hand grabbing the LV, and it's connected to the left ventricle via pulmonary vasculature. There is a large pericardium that contains both of these structures together, which can, of course, impact the right ventricle. We talked about how the RV is thin-walled, And generally, it's supposed to be pumping against a low resistance vasculature system, which means that any changes to pulmonary vascular resistance can really affect an unprimed or an unused to that high pressure right ventricle. Okay. So any sort of increases in PVR really can affect the function of the right ventricle. I drew this out for you because I wanted you to see that the right ventricle is a ventricle too. Okay, so you can see depending on what views you're looking at, whether it's on the left-hand side of the screen, that parasternal long axis image, or the on the right-hand side of the screen, the parasternal short at the level of the papillary muscles. Depending on what image, what view you're looking at, you're going to be seeing different walls of the right ventricle, just like you would of the left ventricle. So this is mostly just to show you that, you know, the RV should be considered a ventricle as well. Now we're going to talk really mostly in this talk about qualitative assessment, meaning how can you use your eyes and your kind of repeat exposure to echocardiography to understand how the right ventricle is doing. I think that really takes us focusing on the morphology of the right ventricle and understanding what dimensions are normal, what thicknesses are normal, and how the septum kind of interplays and what the septum is doing. So we're going to really focus on those areas. When you're using your eye, so qualitative assessment, to estimate RV size, I really think about RV in comparison to the LV. And the best view, I think, that allows us to really compare the two is the apical four-chamber view or the subcostal four-chamber view, because the two chambers are next to each other and they allow you to see how the RV is doing in comparison to the LV. So if the right ventricle is less than 2/3 the size of the LV, then that's normal. That's a normal size. But if you notice that the RV is the same size as the LV, so meaning that the apices of both of these ventricles kind of end at the same spot, then that typically means that the RV is moderately enlarged. If the apex of the heart gets taken over by the right ventricle, or the right ventricle is bigger than the left ventricle, then this typically means that the RV is severely enlarged. Mild enlargement is kind of harder to guess with your eye, I think, but basically you're seeing an RV that may not be quite 2/3 the size of the LV, but it's somewhere between 2/3 and the same size as the LV. And the way that we can use our eyes to assess RV function is to really look at a couple of different things. So first, what is the septum doing? What is the kind of relationship of the septum between the RV and the LV? As you can see here in this image, in a normal looking heart, the LV should be round like a circle, and the RV is kind of stuck onto it like an ellipse. And so that interventricular septum in that parasternal short axis view is really kind of curved, almost like a crescent. The LV looks like a donut. As there becomes to, as RV develops dysfunction, either because of volume overload or because of pressure overload, the septum will begin to flat. And basically the LV will take a D shape. We call it the D shape of the LV. This is a sign that the RV is getting impaired and there are troubles on the right side. So look at the septum and see what the septum is doing. If it starts to get misplaced into the left ventricle and it starts to flatten out, that's concerning. And depending on when it does that, during diastole or systole, it can mean different things, and we're going to talk about that. Also, look at the lateral free wall of the right ventricle. When you are seeing the free wall in the apical four-chamber view, you want to assess how the free wall is moving from the annulus. Is the tricuspid annulus moving up and down? We're going to talk about this. And how does the internal diameter of the RV change? Now I'm trying to see, Steve, do you see that admit popping up on your screen?
Yep, I see. I got it. Thanks
Okay.
for.
Perfect, thank you. Okay, so you can see, here are some examples of what we're talking about. So I would love for y'all to just unmute yourself for a second. On the left-hand side of the screen here is the apical four-chamber image. This is the left ventricle. This is the right ventricle. Notice how the right ventricle basically ends before the end of the left ventricle. So this is 2/3 the size of the left ventricle. This is a normal RV and a normal RV function. Now compare that to this patient. Can anyone share with me, what do you think the size of the RV is in this image on the right-hand side in the abnormal echo? Do you think the size is normal, moderately enlarged, or severely enlarged? And anyone can just pipe in.
Severe.
Severe, exactly right, Chris. That's exactly right. Notice how the apex of the heart is taken up by the right ventricle. The RV looks so big, you almost, if you didn't know that it was correctly oriented, you would think, is this the left ventricle? It's so big. Notice a couple of things. Notice how you can all of a sudden see all of those trabeculations in the apex. We had mentioned earlier that the RV is trabeculated at the apex. So when it gets dilated, oftentimes you're able to see all of these trabeculations and that moderator band a little more easily. Notice how this lateral annulus of the tricuspid valve isn't moving up and down like a piston, the way that we are seeing it here. Look at how robust this bounces compared to here. It looks kind of puny. And in addition, notice how the internal area of the RV is not really changing much over the cardiac cycle. Look at how it changes here and then compare it over here. So this is a severely dilated and dysfunctional right ventricle. Okay, notice also how the LV is really small and underfilled because it can't get the blood it needs to get because the RV is failing. So now let's look at this in a couple of other views. So we talked about the parasternal, we talked about the apical four-chamber view. This is a parasternal long axis view. Here's a parasternal short axis view at the level of the aortic valve. Notice in this image how the right ventricle is, it kind of has recoil. It looks relatively small compared to the LV. This is a normal heart. Compare that to the image on the right. Look at how giant the right ventricle is. It's so big that it's pushing down the septum. Look at what's happening to the septum, especially as the RV is trying to fill in diastole. The septum's getting pushed down into the LV. The LV is small and underfilled. So if that size from here to here in the parasternal long axis view, the RV kind of diameter in this view is greater than 30 millimeters or 3 centimeters in diastole, then that is abnormal. And you can see these little hash marks on the side of the ultrasound image. These are all 1 centimeter hash marks. So you can just see with your eye that this is probably more around 4 centimeters in diameter at that point. So this is a dilated right ventricle, and you can see how the area doesn't change and how dysfunctional it is. Now compare that to the parasternal short axis at the level of the aortic valve. So here's the aortic valve. This is the right atrium. Here is the tricuspid valve that comes into view every so often. This is the inflow into the right ventricle. This is the outflow out of the right ventricle, and there's the pulmonic valve, okay? This is a normal heart here. Compare that to this patient here and how dilated the right ventricle is in this image and how that area doesn't really change throughout the cardiac cycle. So in the parasternal short axis at the level of the aortic valve, if this diameter is also approaching 30 millimeters or 3 centimeters, if it's basically greater than 27 millimeters, then that's dilated. I use 30 in my mind because it applies to both. If it's 30, more than 30 dilated here, 30 millimeters, that's abnormal. If it's more than 30 millimeters dilated here, that is definitely abnormal. All right, so this is another view that we can use to assess the size of the RV. Now, when you're thinking about the RV thickness, so what does that mean? Like, why do we even care about the RV being thick? Because that means that the RV has been chronically being exposed to high pressures and over time has remodeled and kind of gotten muscular in order to overcome the pulmonary vascular resistance. So this is best really evaluated in the subcostal four-chamber image. As you can see in this image, you can see the right ventricle on the top, which is the ventricle wall where that little yellow star is underneath the liver, and the LV is underneath it down below. If that wall thickness in diastole, so when the RV is the most relaxed and is comfortable and not squeezing, right, most relaxed, if that or that thickness of the RV just below the tricuspid annulus is greater than 5 millimeters, then the RV is hypertrophied. Okay, so this is the view that you can look at for RV hypertrophy. Now, if you notice in this image here, you can just see very clearly how thick the right ventricle is here. In this patient, when we measured this, this was basically greater than 10 millimeters, which is consistent with severe RV hypertrophy. So this is definitely something that you want to look at, because when you have patients who have RV thickness, you know that something has been chronically going on, whether they have pulmonary hypertension or some sort of restrictive or infiltrative cardiomyopathy, something longstanding has been occurring, and we need a little more information. Now, when you look at the septum, a really nice kind of image to look at the septal behavior is the apical four-chamber image. You can see here how what the intraventricular septum is doing. So you can notice how, let me just go back here.
What's up? Sorry. Sit up.
I'll just have everyone please mute themselves if you can. Let's see if I can go back. Hold on one second. Okay. I'm going to share my screen again. Okay, here we go. So notice how when you're looking at the intraventricular septum, in a normal patient where the RV is normal, this intraventricular septum is basically placed over towards the right side. Okay, there's an RV placement of the septum and it's kind of midline. That's what you want. Also, additionally, look at the intraatrial septum. The intraatrial septum should also be kind of RV placed and midline. In a patient who has severe RV dilation or dysfunction, typically what will happen is that intraventricular septum will get pushed over to the LV, as you're seeing here, very different than on the left-hand side of the image. And also the intraatrial septum will get pushed over towards the left side. So looking at the septal behavior can really give you an understanding of what's going on with the right ventricle. Now, another really great view for assessing intraseptal behavior is the peristernal short axis at the level of the papillary muscles. So look here at this patient. This is the peristernal short axis at the level of the papillary muscles. Look at the left ventricle. This is the LV. Here are the papillary muscles. There is the RV stuck on top like an ellipse. Notice what's happening as the patient's heart is contracting in systole. You notice the septum just bouncing down. So let's look at it for a second. Flat, 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 flat. You can see it basically bounce down every time the heart is trying to contract. When you see septal flattening in systole, like we're seeing in this patient, that is a sign of right ventricular pressure overload. You know, as I get older, it gets harder for me to memorize things. And I will say that you just have to think about it in a way that makes sense. What is happening in the heart when systole is occurring? Inside of the chambers, the pressures are going up, 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 and up. And when you get that pressure increase, the septum flattens. So that is a sign of pressure overload. Now let's contrast that to this bottom image. Notice what's happening, that the septum is flattening as the heart is trying to fill. So in diastole, you're getting the septum kind of bouncing down and flattening. So let's look at it here. Filling, 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 filling. You see how the septum is just getting pushed down as the RV is trying to fill in diastole. So it would make sense that this would be a sign of volume overload on the right side. If you're seeing flattening throughout the cardiac cycle from systole to diastole, then that is a combination of RV pressure and volume overload. So how can you evaluate the function of the RV with your eye? We talked about this a little bit earlier, but just look at the base of the tricuspid annulus, this lateral annular motion. It should be like a piston moving up and down, and should move really more than, about 1.6, 1.7 centimeters, okay? And so I'm not expecting that in point of care ultrasound, bedside cardiac ultrasound, that we would measure all of these things all the time, but just look at how robust this bounce is. Now compare that to this patient here, where if this is a centimeter distance, it's not even traveling that. So that is one way you can use your eyes to assess the right ventricle. The other way is what's happening in the internal diameter of the RV. It should change by greater than 35% throughout the cardiac cycle. So this area should get smaller. Okay, and that, if you were doing a measurement, would be called fractional area of change. I'm not expecting folks to do the measurement, but I just wanted to show you just kind of like visually what that would look like, which is look at the top image on the screen where the outline is in blue. That's a normal RV. And look at how from end diastole to end systole, that internal area of the RV changes almost in this patient, probably by about 40 to 50%. Okay. It should change by greater than or equal to 35%. If it doesn't, then that's abnormal and a sign of RV dysfunction. Look at the bottom image on the screen where the green outline is present and how minimal that changes from end diastole to end systole. So that represents a patient who has an impaired RV function. And the echo is like also screaming out to you. I mean, look at how big the atria are in the images. You see biatrial enlargement of the left atrium and the right atrium. This is a sign of underlying chronic pathology. Not surprising that something's wrong with the right ventricle. Now, when we think about pressures on the right side, I'm sure a lot of you have heard about IVC and IVC measurements. And I wanted to just touch on this briefly because I think the IVC can be very helpful in certain times, in certain patients, and it can actually be very harmful if you're using it out of context and without understanding what else is going on in the heart. So when you're looking at IVC size and collapsibility, this is a measurement that should be done on spontaneously breathing patients. This isn't something that we do intraoperatively when the patients are on mechanical ventilation, because this is an assessment that is done on spontaneously breathing patients. And I think about the IVC in kind of three categories. I think about the green category, or on this slide, it would be the blue category, which is the good to give fluids category. Right atrial pressures are low. And I think of the red category, which is right atrial pressures are really high, and I need more information as to what's going on with the heart. And then also the gray category, which is right atrial pressures are somewhere in the middle, and I really don't know what that means. Okay, I need more information. So the moral of this story is if the IVC is small, and by small, I mean less than 2.1 centimeters, and it is collapsible by greater than 50%, then that means right atrial pressures are low in a spontaneously breathing patient. somewhere between 0 to 5. We pick 3 just for fun, and the patient will likely be fluid responsive. Okay. But if the IVC is large, meaning it's greater than 2.1 centimeters and it's not collapsing by 50%, it's collapsing or minimally collapsible, less than 50% collapsibility, then the right atrial pressures in that spontaneously breathing patient are elevated. They're between 10 to 20. We would pick 15 as a middle point. But that doesn't mean that the patient needs diuresis. That doesn't mean that the patient is fluid overloaded. All that means is that the right atrial pressures are elevated. So you have to go and get more information. And I'm going to show you an example of how you can get into trouble if you just use the IVC as a marker of whether you should diurese a patient or not diurese a patient. And then the gray zone is the middle zone, which is if the IVC is big, but it's collapsible by greater than 50%, or the IVC is small, but it's not collapsible by greater than 50%, then those right atrial pressures fall right in the middle between 5 and 10, and we typically pick 8 millimeters of mercury as a middle point. This is all in spontaneously breathing patients, okay? And this is kind of a way that we would measure that. We would get the IVC nice and long across the screen in the subcostal view of the IVC. And you can put M mode over the IVC about 2 centimeters away from the diaphragm, where you're seeing kind of in this image, and measure what happens to the diameter of the IVC as the patient takes a sniff or breathes. Also, you could not measure it that way and just, freeze your image and measure the IVC when it's the most dilated in a 2D image, scroll through to when it's the most collapsed and measure it there. That's the other way to do it. So I wanted to show you this to make my point. This patient here has an IVC that's probably a little, just barely over 1 centimeter. Notice how you know it's the IVC because it's going into the right atrium. There is a proximal hepatic vein dumping into it. It's very small. It's very collapsible, even as the patient is breathing normally. So this is a spontaneously breathing patient. Their right atrial pressure is probably somewhere between 0 to 5. We'll say 3 millimeters of mercury because it's the number in the middle of that range, okay? This patient would likely respond to fluids. What about this patient? Notice how big the IVC is. It's going into the right atrium, giant IVC. Okay, so we know the right atrial pressures are elevated, but this patient had cardiac tamponade. Would you ever diurese a patient who had cardiac tamponade? That would be terrible. Okay, so when you see a big IVC, you can't just assume, oh, the patient's volume overloaded. You have to go look at the rest of the echo and see what's going on, because lots of things could give you a dilated IVC. What if the RV is failing? What if the patient has terrible tricuspid regurgitation? What if the patient has a pulmonary embolism? What if the patient has an RV infarct? What if the patient has cardiac tamponade? All of those things can give you IVC dilation and a lack of collapsibility. So don't fall into that trap. Now, what about in our patients who are mechanically ventilated? The IVC is only helpful in these patients when it's exquisitely small. So if the IVC is less than or equal to 12 millimeters or 1.2 centimeters in this patient population, then it's basically 100% specific that the right atrial pressure is less than 10. And otherwise, it does not correlate to right atrial pressure. So you cannot look at the IVC size by itself in a patient who's mechanically ventilated. There are other things that maybe we can talk about at a later time when we're talking about volume assessments that you can look at. But the IVC size by itself in a mechanically ventilated patient is only helpful when it's exquisitely small, 1.2 centimeters or less. Now, I think it's really important as we talk about the right ventricle to talk about differentiating between acute versus chronic RV dysfunction. So in a patient who has chronic RV dysfunction, you will typically have some sort of history, right? Maybe they had LV failure. Maybe they have some sort of valvulopathy. Maybe they have underlying lung disease or pulmonary hypertension or obstructive sleep apnea. They have something that is, increasing the pressures, could be increasing the pulmonary vascular resistance. Notice how in this patient has chronic signs of chronic RV dysfunction and RV failure. Look at how hypertrophied the RV is. Look at how dilated it is, okay? You don't get this sort of hypertrophy overnight. So this patient had to have chronic exposure to high pulmonary pressures in order to develop this level of hypertrophy. Also, notice something else. Notice the heart rate. This patient was walking around kind of living their lives with an RV that looked like this, and their heart rate is normal. That is not the case in the patient who has acute RV dysfunction. When the RV is acutely failing and not used to having that sort of pressure or that sort of dysfunction or those sort of problems, you'll see an RV that's dilated, relatively thin, and the patient will typically be tachycardic because the LV is working in overtime to try to sustain cardiac output. All right, so that is just a really important thing never to miss, is what's happening with the heart rate and how thick and dilated does the RV actually look, to help you differentiate. The other thing I wanted to touch on very briefly is to just remember that when you have a patient who's septic and they are not responding to vasopressors, look at the heart, because 65% of these patients end up developing septic cardiomyopathy. And septic cardiomyopathy is a reversible cardiomyopathy, and it can affect either the LV or the RV. It can affect both ventricles. So this isn't, it's not like, oh, it just chooses to affect the left ventricle. In this patient, I had a patient here who had urosepsis. Notice how they have biventricular failure. The LV is barely moving. The RV is barely moving. Remember what we talked about, that internal area of the RV is barely changing over the cardiac cycle. We treated the patient. A month later, this is what their heart looked like. So this is just to say cardiomyopathy in sepsis requires support. It requires first discovery and then support. And if you support the patients, they can have a full recovery. The other thing I wanted to throw up there is that in patients who arrest, if you understand or know that they have RV failure or dysfunction either going into the arrest, or that you can discover it, during the arrest, this is really crucial for recovery. Patients who have diagnosed RV dysfunction and that is not addressed tend not to recover after arrest. So identifying causes of RV dysfunction can prevent arrest or quickly recover patients from arrest, but the opposite really impairs recovery from cardiac arrest. So now I would love for y'all to unmute yourself. And this is a comfortable environment, no judgments here. This is just so that we have an opportunity as a group to think together and look at these images, okay? So which of the following RV findings are seen in the clip shown here? Okay, so this is an apical 4-chamber image. This is the left ventricle. This is the right ventricle. This is the right atrium. This is the left atrium. This is the same patient in the parasternal short axis view. Here it's at the level of the mitral valve. Here is the LV at the level of the mitral valve. Here is the RV. What do you think? Is this patient's RV severely enlarged with moderate to severe reduction in function? Is the RV mildly enlarged with mild decreased function, or is this a normal RV size and function? Feel free to just unmute yourselves and shout it out.
Looks severely enlarged with moderate decreased function.
Yes, David, that's absolutely correct. This is an RV that's severely enlarged with either moderate to severe dysfunction, and you can tell because look at this RV. The RV is larger in size than the LV. Look at this, what we call the TAPSE, or the tricuspid annular plane systolic motion, or that lateral motion of the tricuspid annulus. It's barely moving a centimeter. Look at how the internal area of the RV is barely changing over the cardiac cycle. Notice what's happening to the intraventricular septum, how it's getting pushed down every time the heart is trying to fill. Okay, so this is severely enlarged with moderate to severe dysfunction. Great job. What about this patient? 58-year-old patient had colorectal cancer, was presenting for a colon resection and coded in the pre-op area after standing to use the restroom before going back to the operating room. Tell me what you think first about the RV size, about the RV function, and if you think this is acute or chronic RV dysfunction, and if there's anything else you see. What do y'all think? This is the LV. Oh, yes, go ahead, David.
Yeah, it looks acute. The heart rate is high. The right ventricular volume is large and not markedly changing in size in the cardiac cycle.
That's exactly correct. This is acute RV failure. This is, look at this heart rate. The patient's tachycardic, the LV is small and underfilled. Look at how big the right ventricle it is. It's bigger in size than the LV. So this is severely dilated. And remember what we talked about earlier. Remember how we said that apex of the RV is very trabeculated. And as it gets dilated, you tend to see those trabeculations more. Look at all of these trabecula you're seeing in the RV. Look at how it's not changing in size. Look at how there's minimal motion of that tricuspid annulus. Maybe it's moving about a centimeter. Look at how giant this left atrium is. Look at the intraatrial septum, how it's getting pushed over into the left side, and the intraventricular septum is bowing over into the left side. What else do you see that's like, oh my God, in this image that could explain what's going on with this patient?
See a terrifying clot in transit.
Yeah, you see a totally terrifying thrombus in the right atrium, basically flopping in and out of the right ventricle. So why do we think this patient coded? Probably because they had a massive pulmonary embolism, right? You see all of this thrombus. And this is the only way to, diagnose a pulmonary embolism with echocardiography is to actually see clot either in the RV or have a patient who's like arrested and you found clot in the femoral veins or the deep veins. So this is definitely concerning. Okay, what about this patient? And I really would like to give kudos to my colleague, Dr. Nibras Bugara up in Albany, New York, who shared this case with me. This is a 74-year-old patient who had severe chronic obstructive pulmonary disease and became profoundly hypotensive after induction for a left lung decortication in the operating room. So these images are from the operating room. The patient has severe COPD and became hypotensive after induction for a left lung decortication. This is a subcostal four-chamber image. This is the left ventricle here. You can see the thick left ventricle. Here's the right ventricle here. Here's the right atrium. There's a left atrium. Here's the IVC. There's a proximal hepatic vein. What do y'all think about this? What do you think is wrong?
It looks like the RV is chronically with dysfunction.
Okay, Emmanuel, can you say it again just because I didn't hear, but I agree with you, there's dysfunction. I just didn't hear the first half of what you said.
The RV is dilated with thickening. It looks more than 5 millimeters. So it may be chronic RV dysfunction.
Yeah, that is so great. So this RV is, look at how dilated it is. It is so large. It's bigger than the LV. And the other thing you should know is in the subcostal four-chamber image, the RV should usually be really kind of underestimated. So if you're seeing it big and this large in the subcostal four-chamber image, then something's wrong. It is big, okay? But Emmanuel picked up on something even kind of more interesting, which is look at the RV, it's thick. There is some thickness to that right ventricle. You can see the wall. It looks about 1/2 centimeter, which would support the fact that the patient probably had some chronic underlying RV dysfunction. We induced them. They got probably a little hypercarbic, probably a little bit hypoxic, and they developed cor pulmonale, and then their blood pressures became low. Notice how large the right atrium is. You know there's some sort of underlying chronic pathology. The RA does not get this big just, yesterday or in like a week, right? And look at how big this IVC is. And you know that the right atrial pressures have to be elevated. And here you have an RV that supports that. So this is my question to you. The blood pressure is 50/30. What do you do? You're in the operating room. What could you do to help this patient? Think of simple things.
Maybe we can offload the pressure if we are using decreasing the peak. And if the patient is not relaxed, maybe spontaneous manual ventilation might help.
Yeah, absolutely, Emmanuel. So you could optimize the vent settings, right? You could make sure you could optimize the patient themselves, make sure they're relaxed, make sure that they're on 100% oxygen, make sure you're adequately ventilating them to reduce the hypercarbia, make sure that you don't have them on a lot of PEEP, right? So optimize the vent settings, and that's what they did. Then they gave the patient epinephrine to support the squeeze of the right ventricle, and they gave the patient vasopressin so that they had a blood pressure supporting agent that was not going to increase pulmonary vascular resistance. And this is what the heart looked like afterwards. The blood pressure improved to the 90s over 50s, and you can see the heart rate has come down and the RV function has improved. Look at that. And that's just such a crazy case. Very simple. One view, one window, subcostal 4-chamber, subcostal IVC. 1 minute. Okay, so I just wanted to thank you all so much for taking the time to join the talk today. We have about 10 minutes left. I wanted to provide an opportunity for everyone to please fill out this needs assessment survey. It's helpful for us to know kind of if what we're doing is meaningful or impactful, or what it is that our global partners really need, so that we can make sure to make this collaborative a successful one. And I also wanted to open this up for questions. We have 10 minutes. Like, do y'all have any questions for me? Anything you want to chat about, or any, cases you've had that you want to discuss, or whatever the case may be? I would love to answer any questions you have. I'm just gonna leave this up here. And I'm gonna turn on so I can see all your videos. Does anyone have any questions at all for me? I mean, I just want to say that, like, this, as an intensivist, as an anesthesiologist, after all of this time, this is still the thing that stresses me out is RV dysfunction and RV failure, because I think we have so many ways of assessing the left ventricle, and we have so many ways to support the left ventricle, whether it's through medications or through mechanical support or whatever the case may be. But we really don't have a lot of ways to support the right ventricle. So much of what we have to do is recognition of when it's at risk and early aggressive treatment. Yes, Kwan, I see your hand raised. Let me see if I can unmute you. Kwan, go ahead.
Hello, can you hear me?
Yes.
Yeah, sorry about the technical. Sarah, this is Young Kwan. What a great focus talk.
Oh,
Very
Young, I'm
impressive.
so glad
Yeah.
you're on the call.
Oh, absolutely. Very impressive cases. I'm sorry, I was on my way work, so I had to do it a little intermittently. But the cases were excellent, and I really would like to learn more about your initiative on this global focus, because this is very a highly valuable program, in my opinion. Couple comments on this very exciting RV talk. The last case you showed, obviously we see them from time to time. Hopefully not commonly, but you see them obviously in the OR or peri-induction settings in various settings. But one thought I had was, would you have given some like IV bolus fluids as well, in that case? And then the other comment I have is, RV is a highly dynamic ventricle, a little bit more compared to left ventricle. Left ventricle can be dynamic too, but I think RV can change from one moment to another moment, and depending on what intervention that you provided. And so the one comment I have is, I think it's important that you kind of keep tracking on the RV function, if you will. So, and I'm sure that you probably would have wanted to highlight that point as well. But it's important that you have a little more dots to connect to really come up with a good hypothesis and provide the best treatment.
That is dead on. And I just want to take a moment to basically introduce Young to the group. Young is one of our cardiologists here at the University of Washington, cardiology, critical care, highly involved and engaged in POCUS nationally and at our institution. I'm so excited that he was able to join and share his perspective, both as an intensivist and a cardiologist. Absolutely correct. There's a couple of things. One is the RV is very dynamic and it changes from moment to moment. And that is why it's so important to do reassessments of it. So if you notice in that last case, they saw the problem, they did the therapy, and then they reassessed it. And you have to do that. And you have to do that in particular with your volume management of these patients. So could that patient have gotten some fluid? Maybe they could have, but you have to be a little bit careful, because it's not like in the operating room space, that's our go-to. We give patients fluid, we give patients vasopressors. They tried those things when the patient's blood pressure first got low. Bolus of fluids, bolus of phenylephrine, those are kind of our go-to things. And the patient didn't respond. And with patients who have RV failure, some of them need volume for sure, absolutely. Like let's say they have an RV infarct, or maybe it's the beginning of a pulmonary embolism or so, and they need that, extra preload to be able to push the blood forward. But you have to be cautious and go little by little, because it just takes a little bit more than too much to kind of tip the right ventricle over. So that would be kind of my point to that, is just to reinforce what Young said, which is that is why it's really important to be able to assess and reassess and reassess. So I did this, I gave a 250 cc bolus, now what's happening? Or the patient didn't respond to my 250 cc bolus, let me take a look and see what else I can do. Other things that could have been done in that case, but take time to do and are expensive, is, maybe the initiation of an inhaled pulmonary vasodilator like epoprostenol or something like that. But not all places have that, and definitely not all places have it readily available in the operating room. If you want it, maybe if you do have it, it may take like 30 minutes or, an hour before you get it from pharmacy, if you can even get it at all. And I would be really interested to know from our global partners, do you have access to inhaled epoprostenol? Like, do you use medications like that? They're quite expensive. And even in the place I used to work before here, we barely could get access to it in the operating room. I would just be kind of, that would be a good thing to help understand.
Yeah, I think that's a good question. You know, whether such therapy is immediately available. The reason why I brought up this fluid was that yes, you can make RV worse. Yes, you can tip the RV off of the maybe a Starling curve or whatnot. You need to have some fluid to work with, I think. And I'm sure in the OR that's usually not the case, but sometimes in the acute kind of unexpected cold situation and things like that, it's sometimes it's possible they just don't have much fluid to work with. So ensuring that there's some adequate volume to begin with is helpful. But of course, it's hard to tell until you give some fluid and see what happens, right?
Yeah. Yeah, totally. That's a really good point. I think we, as anesthesiologists, sometimes don't even think about it because it's like the first thing we do. Like the fluids are right there, the
No, you're
vasopressors
right.
are in our hands. So it's usually the first thing that we do. But you're right. Like in the acute care scenario or in a code scenario, maybe like if you're in the pre-op area or in the ICU or on the floor, people might not think about it. You're absolutely right. And it's always a good place to start because of course, RV needs to be filled in order to push forward. That's a really great point. Thank you so much. Does anyone else have any other questions? Okay, great. Well, that's 8:30. We're right on time. I just wanted to thank you so much. And please remember, we would really like for one of our global partners to present at this next case conference next month. So please reach out to us and we're willing to help however possible. If you want to put together some cases or a little talk, you can always send it to me or David or Bookie. We can look at it and kind of review it together before the presentation. So please, please, please feel comfortable to do that. We would love to get your perspective and, help kind of make this collaborative robust. Thank you. Thanks for joining.
Thank you.
Bye.
Thank you. Bye.